next talk is presented by Charles Goodway. He is consultant hematologist, not yet. No, he's honorary consultant hematologist at Hammersmith Hospital, sorry. And he's post-CCT research fellow in Imperial College, and he'll be presenting. And he is co-sponsored by Pfizer along with UKMS.
Thank you very much. Hello, my talk today is about automated body composition analysis reveals significant associations with mortality in myeloma patients following immunotherapy with bispecific antibodies. I'd like to thank the UK Myeloma Society for selecting this abstract and for Pfizer for the Travel Award. This is my outline and body composition. Right. So essentially, body composition is the relative proportions of the various body tissue compartments, including muscle, bone, visceral, and subcutaneous adipose tissue. And there are many ways of measuring body composition, including DEXA scans. But for the purpose of this study, we did a CT-based method. Essentially, it starts with the patient having a PET-CT scan, which was a PET-CT scan because it's the scan that allows us, to scan a patient from the head to toe. And following data acquisition, there is obviously computation of the body composition with a software, and the results are confirmed by a clinician. So essentially, every slice of the CT image is segmented, every pixel is segmented, and you end up with a different body compartments, in different colors, and you have a computation of the whole segment into volumes for the individual. So essentially, here in blue you have subcutaneous tissue, in red you have skeletal muscle, and in green you have visceral adipose tissue. So body composition is important because it allows an objective quantification of the various body compartments, including bone, muscle, adipose tissue. And unlike the body mass index, you can actually differentiate adipose tissue from muscle bulk. It also allows us to determine the distribution of adipose tissue. For example, we know that visceral adipose tissue carries a much greater cardiovascular risk than subcutaneous and fat. So for this study, our aims were to correlate the incidence of cytokine release syndrome and survival in patients with myeloma who had received bispecific antibodies. And our study population were unselected myeloma patients, 43 of them, who were treated with bispecific antibodies at UCLH. And they all had PET-CT scans, of course, as part of their assessments. And each PET-CT scan was analyzed retrospectively using the DAFS software. We also compared with a control group, which were sex matched for each patient. And these were patients with smoldering myeloma, or MGOS, who also had received PET-CT scans at UCLH. And they had also not received any significant steroids. And our results were, obviously, our patients were well matched with controls, apart from two very important differences. Our controls were slightly older, and there was a high prevalence of CKD in our myeloma patients, as you'd expect. Our patients were heavily pretreated with a median of 5 prior lines of therapy, and about 37% of them had received a previous BCMA-targeted therapy. But for the other characteristics, they were fairly similar, including the BMI. Okay, our results. What did we find? Compared with the controls, we found that patients with refractory myeloma, relapsed refractory myeloma, actually had greater bone volumes, and these were both cortical and trabecular bones, as shown, there we go, there in the image on the left. And we also normalized to the bone index, which is essentially the total bone volume divided by the height squared, and again, that was significant. We didn't find any significant differences in lung volume, subcutaneous adipose tissue, or visceral adipose tissue between our controls and our study group. We also went on to correlate BMI, which is often used in clinical assessments, with our visceral adipose serum. We found that there was actually very poor correlation. While the BMI correlates much better, both for our study group and controls, we found that they were better correlated with subcutaneous adipose tissue, but very poorly with visceral adipose tissue for both groups. And looking specifically at our study group, we found no association between body compartment, body composition, and CRS, both in terms of subcutaneous adipose tissue, skeletal muscle, and total lung volumes. However, looking at patients who died during follow-up, we did find significant differences in that patients who died had much reduced skeletal muscle volumes as well as total lung volumes. But there was no difference in terms of subcutaneous tissue for both groups. In summary, this pilot study has compared relapsed refractory myeloma patients who had received bispecific antibodies with sex-matched controls. And although our control group was slightly older, we found higher bone volumes in our study group, and this may be related to age, with our study group being slightly younger, or the effects of previous zoledronic acid therapy. And we also found that BMI was more strongly correlated with subcutaneous adipose tissue rather than visceral adipose tissue, and there was no association between body composition and CRS, but we did find significant differences in terms of reduced skeletal muscle mass and lung volumes were associated with mortality in our study group. And to conclude with my final slide, as hematologists, we're always determining fitness. And the ways we determine them are actually very subjective. A patient who runs 10 kilometers every day is obviously very fit. A patient who walks into your clinic room with a Zimmer frame is obviously frail. But in between these two, there is a gray area, and we need an objective way to determine fitness, and this is where body composition analysis comes in. And this offers an objective assessment of fitness and health, and can be a biomarker of the likelihood of mortality following treatment. And we can also identify a group of patients that would potentially need intervention prior to intensive treatments. And I'd like to thank our collaborators, and this study was done while I was at UCLH CRF, and it was obviously ably led by Dr. Rakesh Popat. And I'd also like to thank our collaborators at our radiologist colleagues, as well as our collaborators at St. Mark's Hospital. Thank you.
Questions?
Thank you, Charles. Nice presentation. Do you have, other than nutritional interventions, do you have any other interventions that could modify body composition and therefore potentially alter outcomes?
Well, yes, possibly. There are a whole range of additional things, including medications. Zoledronic acid, for example, can probably also alter bone composition.
Can I just ask a quick question? So apologies if I've missed this, but did you include talquetamab, or was it just Elra and TEC?
We did.
Yeah.
Talquetamab patients.
And did you see any drop in skeletal muscle or anything, or body composition more with talquetamab?
Well, unfortunately, we couldn't analyze because we had very small numbers, 43 patients in all, so we didn't look specifically in the subgroup.
Any other questions? Okay, thank you very much. Thank you. Yes, so that is a relatively short session. Just to conclude, and congratulations again to all our bursary winners. So I was just going to take the opportunity to remind about the joint UKMS and Myeloma UK webinars that you can access either via Myeloma UK or UKMS. So they are gaining in popularity and are very worth attending. And also, again, to remind about the talks being recorded and accessible on the UKMS website. So I think with that, we'll close the session, and if everybody could reconvene at 1:25, please. Thank you.
For a long session.